welcome all of you people on this dais. As Dr. Charuta said, pediatrics are not the miniature adults. There are so many anesthetists in our country that they are the occasional pediatric anesthetists. They are not specialized. Those who have not done the fellowship or the specialized in pediatric anesthesia further courses which are there now up to DM pediatric anesthesia is there, but majority of the population, I'll say more than 90% of the population, they are the regular pediatric anesthetician. They are doing practice, and moreover, those who are working in the institutes, they have a different problem, and because the teamwork is there, a lot of people are around, and but those who are practicing at the small setups, it is this symposium is going to give a lot of insight about that. And for that matter, the three speakers are there who are going to give their insights about the three different topics. And we have two eminent chairpersons to put into this session and enlighten on this session all the insight, because both of them, they are the stalwarts in the academic field. One is Dr. Bala Bhaskar, who doesn't know him in the country and outside the country, being he is one of the hardcore teaching faculty in the Faculty of Anesthesia. Now he is being in the position of professor in the Ballari Medical College, who is holding as a head of the Department of Anesthesia and Critical Care Medicine in that. And we know him since he's a GC member to editor-in-chief, and then past president of our own association, ISA, and he is currently holding the World Federation of Anesthesiologists (WSA) as a publication committee member, and is a member secretary of IEC WIMS Bellary, and adjunct professor of KMC Manipal also. And for his achievements, he was, as I said, he was past president of Indian Society of Anesthesiologists and editor-in-chief, I said, and he was coordinator for the formulation of 5 ISA practice guidelines, and BOS member of UGPG, RGUHS, this is the University of Karnataka, and he has a publication, over 60 publications, and his areas of research, areas of interest are research to set up the guidelines, education, and simulation is the area of interest. And being he is one of the most well-known personality, and Pradnya is the most hardcore pediatric anesthetist. N number of fellows are trained under her in Mumbai. I know her since many years. She conducted regional anesthesia in Pune long back, maybe around 2010-9 in Noble Hospital. There was no place to sit for the delegates, and since then people realized that pediatric anesthesia can be practiced, regional anesthesia in our area, this region, and a lot of corners of Maharashtra. So I welcome both the chairpersons and all the delegates and the speakers. Thank you so much.
Okay, thank you, sir. Now I invite Dr. Balaji Asegavkar to introduce Dr. Rashmi Shingade.
Good evening, everyone. Office bearer, President Sale sir, Honorary Secretary, and all office bearers of Maharashtra State Chapter of ISA. And we are really fortunate to have chairperson for this meeting, Dr. Bala Bhaskar sir and Pradnya madam. Now I would like to introduce you the dynamic lady from Nagpur city branch, who is a consultant anesthesiologist and director of Children Orthopedic Care Institute. She is vice president of Childhood Disability NNM Foundation. She is ex-registrar from Tata, and she already have fellowship in advanced anesthesia from Asian Hospital, Seoul, South Korea, as well as fellowship at Royal Orthopedics Hospital. I know she is a very active member of Indian Society of Anesthesiologists from Nagpur City Branch. Welcome you, madam.
Thank you, sir. Thank you.
Okay, welcome Rashmi,
Thank you.
our dynamic president. And now I'll introduce to you Dr. Shri Gopal Bhattad. Can I have the slide, please?
Sure, ma'am.
Dr. Shri Gopal Bhattad is a consultant anesthesiologist, intensivist, and pain physician from Asian Super Speciality Hospital, Aurangabad, that is Chhatrapati Sambhaji Nagar now. He is affiliated to as pediatric anesthetist with the NGO project Smile Train since last 20 years. He has served as joint secretary as well as vice president of ISA Aurangabad, and we hope to see you as president as well, Shri Gopal. A winner of Best Paper Award at national level twice. He has delivered many guest lectures at state and national conferences. I came across him when I was editor of MSCISA News, and he had contributed an article on pediatric regional anesthesia at that time. Welcome, Dr. Shri Gopal.
Thank you.
And now I invite Dr. Samir Sohni, our treasurer, to introduce Dr. Vinit Bedekar.
Good evening. It's my pleasure to welcome the young and dynamic pediatric anesthesiologist from Vijaywadia Hospital for Children from Mumbai, Dr. Vinit Bedekar. He is there as senior consultant in pediatric anesthesia department from Vijaywadia. He has presented, authored and co-authored many papers and posters at state, national and international conferences. He has completed his fellowships in pediatric anesthesia as well as pediatric regional anesthesia. He has won many awards in the anesthesia quiz competitions and case presentations throughout his postgraduate curriculum. First annual conference of ISA Gujarat in 2018, he was invited to deliver a lecture on the pediatric anesthesia for occasional anesthesiologists. As we are discussing right now, that many of us are not full-time trained pediatric anesthesiologists. So he was also given the talk in Surat conference. I welcome Dr. Vinit for this today's symposium. Welcome.
Thank you, sir. Thank you.
Thank you, Samir. Now let us begin our academic session. And I invite Dr. Rashmi to begin with her presentation. That is bronchoscopy for foreign body in a pediatric patient. How I do it. Rashmi, please.
Yeah, I'm just sharing my
Yeah,
screen.
sure.
Is it visible to all?
Yes, ma'am. Visible.
Yes.
Yes,
And I'm audible also?
Yes,
Absolutely,
yes.
ma'am.
Respected office bearers of Maharashtra State Chapter, President Dr. Sare sir, Vice President Charuta ma'am, President-elect Balaji sir, Honorary Secretary Avinash sir, Treasurer Samir sir, and Chairpersons Balabhaskar sir, Pradnya ma'am, and the delegates. A very good evening and warm greetings from ISA Nagpur. At the outset, I would like to thank the organizers for providing me the platform to present my work in this session, how I do it. Thank you so much for that. And that's a very interesting and topic and very close to my heart also. A tracheobronchial foreign body aspiration and providing anesthesia for bronchoscopy for such kids. Thank you so much. So tracheobronchial foreign body aspiration is the most common emergency procedure in children with very serious life-threatening complications. The early diagnosis and removal are associated with decreased morbidity and mortality. So before I actually start with the anesthetic management, like how I do it, let's go through some of the incidences and how I assess the child and before taking to the operation theater. So it's the incidence is most frequently seen in children under the age of 5 years, and the peak incidence is between 6 months to 3 years, and maybe a more physically active quite seen in more in male child. The other contributing anatomical factors are relatively high position of larynx and epiglottis, the narrow airways, immature protective reflexes like swallowing and chewing. The anesthetic considerations are like anesthetizing a child with marginal respiratory reserve is a unique challenge, and sharing the airway with the surgeon is an added risk. So complete cooperation and good communication between the anesthesiologist and the surgeon is utmost important. From the start, it has to be made very clear to the surgeon that the airway, it belongs to the anesthesiologist, and only when you are comfortable, then only hand over the child to the surgeon. So particular considerations in pediatrics are particular to the patient population because they have a very low respiratory reserve and tend to desaturate very fast, and the development of hypoxia is very sudden. And for the airways, for the anatomical factors, they have a very small caliber and softer tissue. That's why they are very prone for bleeding, the perforation, and as such the trauma, and very high incidence of laryngospasm during emergence. The gold standard for diagnosis and management of foreign body bronchitis is rigid bronchoscopy. Just short bit of the history. The Gustav Killian was the first one, who was a German laryngologist and a founder of bronchoscopy, to use a rigid bronchoscope in 1897, and he retrieved a foreign body from the right main bronchus. Later on, the Javier Jackson, he was an American otolaryngologist who laid the platform for the modern day rigid bronchoscope, what we are using. Then came the flexible bronchoscope, and Shigito Ikeda from Japan, he was the innovator of that. So these are the two types of bronchoscope, the rigid one and the flexible one. The rigid bronchoscope is the gold standard for obvious reasons, because it provides you with complete control of airway. That's the most important thing. It has got a huge, the large diameter. So many instruments, they enable wide therapeutic procedures to be performed. The only thing, it requires general anesthesia and demands skill of anesthesiologist as well as surgeon. So whosoever is handling the airway, be it the anesthesiologist or the surgeon, the maintenance of a patent airway is the responsibility of both. So this is the rigid bronchoscope. We have the distal end, the proximal end, that's the eyepiece, and the end at the 90 degrees where we connect our circuit, usually the Mapleson F, and the one at 45 degrees is the instrumental channel. It's the universal connection, so our circuit can connect it directly. So the various sizes which are available, so mostly 3 to 3.5 size of the Storz rigid bronchoscope, what we routinely use. This is a flexible one. Flexible fiber optic bronchoscope has got a very improved optical resolution. It permits the visualization of entire airway, less invasive, needs only IV sedation and topical anesthesia. But then I personally don't use it. It is more useful as a diagnostic device when the foreign body is distally lodged, and maybe you're in a case of a suspected foreign body where we are not very sure whether the aspiration is there or not. So, and it has got a very small instrument channel, and that limits its clinical use. The anesthetic consideration for bronchoscopy. So there is a competition between the I won't say a competition, but then it's between the bronchoscopic and the anesthesiologist. And the procedure is like that it induces a very strong hemodynamic response, high airway resistance. So, and it's always, and most of the time, it's an emergency procedure in an unprepared, poorly assessed, and impaired respiratory function child. So, all the times, the maintenance of an effective airway must be the first priority. Maybe the surgeon or the anesthesiologist, whosoever is at the head end. So, bronchial foreign body aspiration is potentially life-threatening, and sudden death due to acute asphyxia is known. And for the laryngeal body, it is as high as 45%. So even the partial obstruction can become complete at any time and can lead to severe respiratory distress, and it becomes a nightmare for any anesthesiologist. And if it's a long-standing foreign body, it can cause chronic lung injury. As I said before, the gold standard is rigid bronchoscopy. The clinical presentation of a child with a foreign body aspiration it can vary depending on what kind of foreign body it is, where it is lodged, and how much duration has been passed from the aspiration. So a child can be asymptomatic and can be in a severe respiratory distress. So the history from the parents, like history of choking followed by cough, is very important. Whenever a child comes with this, I personally go and take history from the mother. And if the history of choking and coughing is there, it is very likely that it has to be a foreign body aspiration. Some children may present with stridor and cyanosis, and this is mainly with the laryngeal foreign bodies or a tracheal foreign body, where the child could be cyanosed, and you have to take it directly to the operation theater. A long-standing foreign bodies might present with fever or chest infection like pneumonia and all. On examination, it is always better to confirm the site. So I always check personally. So and look for all the diminished breath sounds on one side, or maybe bronchial crepitations for a long-standing one. X-ray chest, yes, it's the main investigation what we do, and but majority of the time the body, I mean the foreign body is not radiopaque, so we can't see it, and in early 48 hours it's difficult to locate. But then the secondary changes, secondary to the obstructions, could be the obstructive emphysema, the atelectasis, or pneumonia. The most common site for the lodgement is the right main bronchus. If you can't see the foreign body, there can be a hyperinflation of the affected lung. So mostly the foreign bodies are either organic or inorganic. The nuts and the seeds, they may swell, and a partial obstruction can become total anytime. On the other hand, the inorganic foreign bodies can be sharp objects, and that may perforate the airway, leading to trauma and bleeding. Coming to the anesthesia technique, first is the assessment. As I said earlier also, the history and physical examination is at most important. Fasting guidelines, we usually don't follow in an emergency case, and if the child comes with full stomach and with stridor and all, it is better to put in a nasogastric tube and aspirate and then take directly to the operation theater. But in a long-standing case where the child is relatively stable, we can follow the fasting guidelines for up to 2 hours for the clear fluids. Investigation I have already told. And the other medical therapy, the child has been given the steroids to counter the laryngeal edema and all the inflammation, antibiotics and bronchodilators. So bronchoscopy is a procedure performed by experienced anesthesiologist and an experienced surgeon under optimal conditions. Informed high-risk consent is must. Informed, I mean that it can be, terribly simple and simply terrible kinds of case. I mean, it can be a nightmare. So the informed high-risk consent, right, from preparation of the patient for the emergency tracheotomy to the thoracotomy, and could be a death on table, has to be explained to the relatives. Goals of anesthesia are as in any other case, like maintaining adequate oxygenation, rapid return of airway reflexes, and prevention of pulmonary aspiration. And monitoring, yes, SpO2, ECG, ETCO2, and blood pressure, if that is standard for any other case. IV access, yes, IV fluids round the clock, and a full 5 minutes pre-oxygenation with 100% oxygenation. We need a complete, as much as possible, of denitrogenation. Pre-medication, I usually give, in infants, I prefer atropine, and little older kids, I give glycopyrrolate. The anticholinergics, they serve two purposes: to decrease the secretion, as well as they attenuate the response, like the hemodynamic response of bradycardia and all, to the instrumentation, that is a rigid bronchoscope. IV fentanyl is a question of choice. I avoid 14, but fentanyl I usually give in older kids, and 0.5 to 1 microgram per kg, and a short dose of steroid. I mean, many of us may not agree on the prophylactic use of steroids, but then I give it. Induction, if the patient in an emergency cases, is always a rapid sequence induction. And if the child is fasting and all, then we can go for the other things, like not in a rapid sequence one. The choice of induction would be intravenous and inhalational both. I mean, no studies I have found on evidence that the one is superior to the other. Both are equally good. It's like what you are comfortable with. I myself is comfortable with the intravenous induction. So it is either ketamine or propofol, and the inhalation. Am I audible? Hello. Hello.
You are audible, Rashmi. You are audible.
Yes,
Very well audible.
Okay. The other method of induction is inhalational, where we induce with 100% oxygen with either isoflurane and sevoflurane. I personally use sevoflurane. If it's available, it's better to use sevoflurane. So that's the induction. It is your choice. I use intravenous, and after that muscle relaxation with the scoline and then a laryngoscopy. I usually spray with opiclots, epiglottis, and with the lignocaine 1%, and maintenance, and then only I hand over it to the, after doing the laryngoscopy myself, and then hand over to the surgeon. And maintenance is usually with oxygen and sevoflurane. Nitrous oxide is usually avoided for obvious reasons. If there is a obstruction, I mean post-obstruction emphysema already, so it might increase and can have serious consequences if the air trapping occurs. So I usually avoid it. And if the procedure is taking longer time, and better to give a non-depolarizer, that's the atracturium. So once the once the patient is relaxed and it is given to the surgeon, the control ventilation is usually started, and control ventilation with muscle relaxant, oxygen, and inhalational agents is continued. And there is no question of coughing or airway trauma. The surgeon also get a good operative field. The airway block I have mentioned only for diagnostic kinds of this bronchoscopies, where we give the superior laryngeal. In the older kids, we can give. I have done cases with this superior laryngeal nerve block and transtracheal lidocaine spray, and flexible bronchoscopy can very well be done with that. Yes. So ventilation, we have two choices: spontaneous and positive pressure ventilation. Apneic oxygenation is usually not done nowadays because of more incidences of hypercarbia and all. But the spontaneous ventilation, if is desirable, till and the positive pressure is pressure ventilation is also, it's your choice. But I preferably use controlled ventilation. Spontaneous ventilation is supported for mostly the proximally located foreign bodies, and which require a very short duration of time. Otherwise, it is not indicated because of intraoperative body movements and late recovery, or maybe a very low success rate of foreign body movement. Only for diagnostic purposes, it can be used. Positive pressure ventilation, it is an IST piece which we connect to the side stream of the Stall's bronchoscope, and that allows a volatile anesthesia, oxygenation, and ventilation. And there are very less episodes of coughing and desaturation. And whenever there are any incidents or episode of hypoxia or something, we can just take it out to the mid trachea, occlude the eyepiece side, and we can very well ventilate. So the positive pressure ventilation, it prevents coughing and the resistance. It provides very optimal surgical conditions. And the positive pressure ventilation can sometimes convert the partial obstruction to the complete if there is a dislodgement of the foreign body distally. Maintenance is usually with 100% oxygen, and of course, sevoflurane is the inhalational agent of choice for obvious reasons, because it has a rapidity of induction, recovery, good bronchial muscle relaxation. Only high gas flows are needed to maintain the depth of anesthesia, because there is loss of the ventilation from around the scope. So pollution of the OT atmosphere can sometimes be a problem, but otherwise it's the inhalation agent of choice, and I always use 100% oxygen and sevoflurane. After the retrieval of foreign body, it is the check bronchoscopy is must for any residual foreign body, any trauma, and to look for any bleed. After the retrieval of the foreign body, if it's had been an uneventful procedure, no complications, no episodes of hypoxia, hypercarbia, or for that matter anything, a bag and mask ventilation is continued till adequate spontaneous ventilation is reached. But endotracheal intubation and mechanical ventilation is indicated in event of any complications, like what I've said, like hypoxic episodes, or if the procedure is taking very long, and if there is any neuromuscular blockade, that's the residual blockade. Post-bronchoscopy algorithm is also very important. Like if it needs a very close observation in IPCU, and then a stridor, you have to look for stridor, bronchospasm, bleeding, and all this can be tackled with the humidified oxygen, like plain saline nebulization, or with bronchodilators and a dose of steroids. ABG is done only if indicated, like if you're suspecting a hypercarbia, or there are many episodes of hypoxia intraoperatively, then only ABG is indicated, otherwise not. The check X-ray also is important to look for any pneumothorax or the lung expansion. Monitoring is same, and thoracotomy is sometimes needed for a foreign body if it is dislodged more distally, or there is a bronchial wall tear. That's an immediate thoracotomy. Then it will have to go directly for the immediate thoracotomy. But if a dislodged foreign body, you can plan it at a later date with a proper preparation. Complications are related with the foreign body itself or with the procedure also. With the instrumentation, the child may land up with laryngeal edema, complete airway obstruction, or the failure to remove it. Can go for hypoxia, hypercarbia, can aspirate the stomach contents. The circulation, the cardiac dysrhythmias and cardiac arrest, they are always secondary to the hypoxic episodes and hypercarbia. Even in neurological, the convulsions are all related with hypercarbia, and even a death. So the death is most common, and in 2006 in United States, there were as many as 4,100 deaths reported related to the aspirated tracheobronchial foreign bodies. And the laryngeal and tracheal foreign bodies have the highest rate of death, as high as 45%. So it's quite a common complication. And the timing of this serious complication is during actual removal of the foreign body. While taking it out, the foreign body, if it is large, it is swelled, organic one, it may just get stuck at the corns, causing a complete airway obstruction. And it needs immediate retrieval. If the surgeon is not able to take it out, it has to be pushed down to any one bronchus to allow the ventilation. And in times, the foreign body may fall into a good lung, again compromising the gas exchange. And in some cases, you have to go for an emergency tracheostomy also to maintain the oxygenation. So to conclude this, anesthesia for pediatric bronchoscopy is a unique challenge, and the communication between surgeon and anesthesiologist is must. Adequate plane of anesthesia, like a deep plane of anesthesia, is needed till the end of the procedure. And the most deep, like while taking out the foreign body, at the cords, the child should not cough, or the airway resistance should not increase. So many a times I give a dose of propofol. In the end, I might increase the concentration of sevoflurane while the bronchoscope is being taken out of the cords. So the rapid emergence and the recovery of protective reflexes are desirable. For this, the short-acting drugs like propofol, fentanyl, and sevoflurane, they can facilitate these goals. I usually avoid sedatives. Midazolam I don't give. I use propofol, fentanyl, and sevoflurane. So expertise of the anesthesiologist and the expertise of the surgeon, a clear surgical plan, a proper preparation, and a familiarity with the equipments is the key to the successful management. Familiarity I always check the bronchoscope of the surgeons. At our hospital, many times different pediatric surgeons, they come and they have their own bronchoscope, but I always make it a point to check it. I always connect my circuit first and always check whether it is patent. Most of them, sometimes they don't, check it, and it may be blocked and all. So I always do it before. So there's familiarity with the equipment is very important, and that's what is to the success, key to the successful management. Thank you very much. Thank you so much.
Oh, thank you, Rashmi. Wonderful presentation. And since it is a high profile, high adrenaline case that goes on in bronchoscopy, yeah. So wonderful account of it. May I invite the next speaker, Dr. Shri Gopal Bhattad, to present this topic, MRI for pediatric patient.
Yeah, sure, ma'am.
We will have the comments and discussion about these topics by chairpersons after he finishes the presentation. So, Shri Gopal, please.
You want to have at the end of the session, Charuta?
Yeah, both these, how I do it, will finish. Then, madam, will have the discussion.
Okay.
Not able to share the screen. Just 1 minute. Yeah.
Fine.
The slide is visible?
Yes.
Yeah.
Yes, sir, visible.
Yeah, sure. Yeah, good evening, everyone. And the topic given to me for today's presentation is anesthesia for MRI in pediatric patient. I'll straight away go to the topic. As we all know, the anesthesia for MRI is the least preferred for the anesthesia for any anesthesiologist. Like any senior anesthesiologist, will not prefer to go to the MRI room to give the anesthesia for a pediatric patient. So usually there is a tendency to send a very junior anesthesiologist to the MRI suite to give anesthesia, and that is the major problem in giving anesthesia, safe anesthesia to a pediatric patient in MRI room. Now let us consider a few things about MRI. What is different in giving anesthesia to the child in MRI suite? Let us understand a few basic things and then we'll move on to the anesthesia techniques. MRI is considered to be one of the safest of all the diagnostic radiological procedures apart from ultrasound, which is employed in medicine. Despite the safety reassurances, MRI creates an extremely powerful static magnetic field, rapidly changing radiant magnetic fields, and radio frequency electromagnetic impulses. And these impulses can impose potential hazards. The prevalence of MRI in pediatric patients is increasing nowadays because there are obvious advantages of MRI over other diagnostic modalities. Like it gives high resolution imaging, so the better it leads to better anatomical and functional differentiation of the tissues. And the most notable advantage of MRI over all the other radiological investigations is it lack the ionizing radiation potential. So now, from outside of the operating room, the intraoperative MRI in OT is also now becoming common because the MRI intraoperative MRI for neurosurgical procedures, for brain tumors, or for epilepsy surgeries, or for movement disorder surgeries. So the MRI is present inside the OT also now. When we are dealing with pediatric patients, obviously there is a high level of anxiety. So the demand for sedation or anesthesia for getting better image quality is high. You want a very calm child for 40 to 45 minutes lying down, which is usually not possible. Like awake child may not be able to lie down for 40-45 minutes. So you need to give some sedation or some anesthesia for these children. And the main problem with anesthesia in MRI suite is the MRI compatible equipments, which are most of the MRI suites, these equipments are not available. So these availability or unavailability of equipments, they pose some unique challenges. These kind of challenges which are not present in the operation theater when we are routinely administering anesthesia to the other children. So the first priority should be the safety of the pediatric patient, but this itself is at stake in the neglected area of MRI suite. So we anesthesiologists, we must be aware of the unique challenges which are present and how to overcome them in MRI. So coming to the unique challenges in MRI suite, there is a strong magnetic field is present. This strong magnetic field is present when the patient is being scanned or when patient is not being scanned also. Routinely 0.5 to 3 Tesla MRIs are available, but when we consider an example of 1.5 Tesla MRI, the magnetic field strength is 30,000 times more than that of Earth's geomagnetic field. So it's a pretty strong magnet. That is why the health provider and the patient both must remove the ferrous objects. Otherwise, it may lead to injury to the health provider or patient, or it can damage the equipment. Non-ferrous internal metallic implants, they do not interfere with the MRI imaging, so that is not a problem. But ferrous internal implants, they are an absolute contraindication for MRI. You need MRI compatible anesthesia machine and monitoring devices. Now, I really doubt how many MRI centers all over Maharashtra are having MRI compatible anesthesia machine. Yes, MRI compatible pulse oximeters are available in most of the MRI centers, but this is seriously lacking in most of the centers. Now, MRI has got a cylindrical design. So because of this design itself, there is a limited access to the patient, especially the head end of the patient is not accessible. And it produces loud noise. This noise level is around 90 decibels. Now, normal hearing decibel, like around 70-75 decibels of noise we can tolerate, a normal human can tolerate, but 90 decibels can become too much. And that this itself may be the reason why these children or the adults, they require sedation for the noise itself. Another thing is claustrophobia, which can be troublesome in children as well as in pediatric patients because of the cylindrical design. Another thing is they use iodinated contrast media in while doing an MRI, so which itself can lead to mild to severe anaphylactic reactions. Coming to the challenges posed to pediatric patients in MRI suite, MRI room itself sometimes or most of the time it is ill-equipped and it is neglected with limited resources. There are lack of adequate equipments, monitoring devices or emergency drugs. And you tend to require, and these children, they require deeper sedation or sometimes they require general anesthesia to avoid the movement for 40-45 minutes. So, and it is also often noted that the NDVM status and informed consent, they are taken casually in MRI room because it is not an OT atmosphere, so they're not routinely used to it, and especially the pediatric patients, they are not routinely used to it. So the NVM status or informed consent can be taken casually. So we should specifically take note of this and should specifically ask about this. Preoperative evaluation is not possible just before the procedure, or it is done just before the procedure, and preoperative evaluation is not done earlier. So the less time is there to take the call about the plan of the anesthesia. IV access can be difficult in smaller children in MRI suite because this atmosphere is not familiar to us and the assistants are not used to it. So usually it is a better practice to ask the pediatrician or the pediatric surgeons who are sending the patient for the pediatric patient to the MRI to get an IV access beforehand only, and then send the child for MRI. Often medically complex patients are there for MRI, like the patients having various neurosurgical disorders or neuromuscular disorders or cardiac disorders. So they may complicate the things for you. Limited access to airway and breathing during study is probably the most difficult part of the while anesthetizing the child in the MRI suite. So these children often require deeper sedation. So these deeper sedation sometimes can lead to apnea with need of emergency intubation when patient is inside the cylinder of the MRI. So it can be can create a dreaded emergency. So tendency to send, as I already said, there is a tendency to send less experienced anesthesiologists to the MRI room. So this I request all the medical centers that this should not be the case, especially when you are dealing with a pediatric patient. You should send an experienced anesthesiologist dealing with pediatric patient to the MRI room, or at least anesthesiologist, if he is not comfortable, he can another anesthesiologist can accompany the person to help him while managing such small kids. Routine fasting guidelines, there is for elective procedures like the rule of 2-4-6, that is no clear fluids for 2 hours prior to the procedure, no breast milk for 4 hours prior to procedure, no solids for 6 hours prior to the procedure should be followed when we are giving anesthesia for children in MRI. Informed consent should be obtained. The child must be accompanied by a responsible adult. We must ensure this thing. And whenever possible, you should engage the child in preoperative discussion. If obviously, if you can understand, but that can improve the cooperation of the child for taking IV line, or for you may require a little less sedation in such children. Obtain proper informed consent and inform the proposed sedation technique to the parents. What are the alternatives to the sedation or associated risks and benefits? Coming to the preoperative evaluation, we must note down the history of the child, and what the medical conditions the patient is having, what is the indication for MRI, which location the child is coming for, which MRI, like whether the child is coming for cardiac MRI or brain MRI or the limb MRI. We should note that, and we should also note the ASA grading after knowing the associated comorbidities. We should check the relevant investigations reports. We should perform the thorough airway assessment before injecting any sedative drug. We should ensure the fasting interval. And specifically, we should note the history of respiratory infection, recent respiratory infection or fever. And one common thing in pediatric patients is tonsillar hypertrophy. We should specifically check for this. And if there is a history of obstructive sleep apnea in such children, then obviously we may like to take control of the airway by either intubating the child or use of the laryngeal mask airway rather than just giving intravenous sedation. We should specifically look for any allergies in the children. Now, coming to preoperative preparation, if the patient is going to require some sedation or general anesthesia, you should ensure a very good IV access. If sometimes the IV access is taken outside and if the injection is painful and you try to inject the drug from this painful IV line, when the child is inside the MRI console, the patient MRI cylinder, the patient can move just because of this painful injection. So you should, in that case, you should take a fresh IV access specifically on the lower limb. I prefer to take the IV access on the foot in such cases. Check the oxygen source and pressure. This is also not like obvious. The oxygen pressure we should check in all the MRI. If you are not familiar with that MRI environment, so you should always check whether the oxygen source is there or the pressure is adequate. Should always check the anesthesia equipments, whether they are MRI compatible or not, proper size LMA tubes, ambu bag, breathing circuit, jar circuit, Bain circuit, masks, suction catheters, and central suctions. All these things are available. Now, what is desirable is MRI compatible pulse oximeter, anesthesia workstation, and monitor. But most of the MRI centers, the only MRI compatible pulse oximeter is there. But you should specifically ask for anesthesia workstation, which is MRI compatible, where the volume of the cases is more, and the MRI compatible monitor can also be asked for. Ensure availability of anesthesia and emergency drugs, and it's very vital. Before you start the case, you should check the availability of the drugs. Ensure no ferrous material is present with the patient and as well as the healthcare provider yourself also. Anesthesiologist experienced enough to manage the pediatric airway should be present for all the pediatric cases. Now coming to the drugs which are used to sedate the children in MRI room. Hello. Yeah. The most common drug which is used is chloral hydrate. This is usually preferred by the radiologists and the pediatricians. It is in sedative hypnotic. It has got no analgesic action. It acts by acting on the GABA receptors. It has got a slow onset of action. It is available as a syrup. It is given by oral route, and it has got an onset of action of 30 to 60 minutes and duration of action of 60 to 120 minutes. But in sicker patients or neonates, it can lead to resedation because of the prolonged half-life. Usually at clinical doses, it does not produce cardiorespiratory depression or respiratory depression, but if the child's age is less than 6 months, this may not be predictable. So usually we try to avoid if the age is less than 6 months. Side effects are nausea, vomiting, agitation, and prolonged sedation. Should be avoided in renal or hepatic dysfunction because it is extensively metabolized in the body and metabolized in the liver, and it is excreted. The active metabolites are excreted through kidney. So renal and hepatic dysfunction should be very careful. Routine dose is 50 to 100 milligram per kg. Maximum dose is 2 gram, and it is the first line drug used in MRI centers. The sedation success rate is around 85 to 96% in the children less than 2 years, according to one published study. But this success rate can significantly drop down to 75% if the child's age is more than 2 years. And fasting before chloral hydrate is usually not practiced across the MRI centers, but it is questionable, but it is advocated that you should follow the fasting guidelines even with chloral hydrate also. Better sedative drugs are now available with shorter duration of action and rapid onset of action. So if the anesthesiologist is present, he will usually not prefer chloral hydrate, he will prefer other agents. Coming to midazolam, yes, it is a very popular drug, sedative, hypnotic, and it has got amnestic action. Onset of action is 3 to 5 minutes, duration is 30 to 45 minutes, and it is recommended as the first line sedative drug for imaging purpose. But more popularly, or I personally use it as an adjunct with dexmedetomidine or propofol or ketamine, because if used alone, it has got a high failure rate. Deeper sedation doses or co-administration, they can lead to respiratory depression. So you need to monitor the respiration or SpO2 throughout when you are using midazolam. It has got a specific antagonist like flumazenil, and which is used in a dose of 0.01 to 0.02 milligram per kg, and maximum dose is 1 milligram. Another popular drug used is propofol, which is highly potent and popular. rapid onset and offset of action is its beauty. That is why it can be titrated. Dose a bolus can be given in usually the pediatric patients, they require a higher doses, 1 to 3 milligram per kg bolus, and 0.5 to 1 milligram per kg can be supplemented every few minutes for shorter procedures, or it can be used in the infusion in the form of 2 to 5 milligram per kg per hour infusion. The side effects are pain on injection site, cardiorespiratory depression, or airway obstruction. We should be very, very careful about airway obstruction when the patient is in MRI, when we are giving anesthesia for children in MRI suite, because airway obstruction, the head end of the child is not accessible, and if the patient develops airway obstruction, it can create an emergency. So you should be aware of this thing, and you should manage the patient accordingly. And propofol, I usually prefer to use propofol with ketamine. Like small dose of ketamine is given, then little boluses of propofol are given. That usually suffices in most of the patients. Sevoflurane, it is a popular inhalation anesthetic agent for pediatric patients. It has got rapid onset of action and rapid recovery, but usually it is used only when the patient is either intubated or LMA is there with spontaneous or controlled ventilation. You can use even with the spontaneous ventilation also, but you should monitor the end-tidal CO2. It can lead to respiratory depression or apnea, so preferably use with controlled ventilation only. Another very popular drug in pediatric patients is ketamine. It is an NMDA receptor antagonist which produces sedation, analgesia, and amnesia. Onset of action is 1 to 2 minutes and duration of action is 10 to 15 minutes. But the prominent side effects are hallucinations, delirium, secretions, nausea, vomiting, tachycardia, and convulsions. That is why, because of these side effects, usually it is combined with midazolam, propofol, or dexmedetomidine. For hallucinations and delirium, you can use midazolam or propofol. For secretions, you can use anticholinergics like glycopyrrolate or atropine. For nausea vomiting, you can use ondansetron. For tachycardia, you can combine propofol, dexmedetomidine with ketamine. So that is why ketamine can counterbalance the cardiorespiratory depressant effect of propofol, and the prolonged recovery of dexmedetomidine can be reduced by reducing the dose requirement of each drug for MRI sedation in children. So if you use the two drugs, the drug requirement for dexmedetomidine as well as ketamine comes down. So dexmedetomidine is another attractive drug. It is an alpha-2 agonist with sedative analgesic properties, and it does not produce respiratory depression. So that is the beauty of this drug. It has got rapid onset of action, but it is slightly more than midazolam and propofol. It is 7 minutes, and elimination half-life is 2 hours. It has got biphasic response. Initially, it will produce hypertension, which is followed by hypotension and bradycardia. So it should be given as a slow bolus over 10 minutes. And to counter the bradycardia, we can use glycopyrrolate or atropine, or to counter the hypotension, we can slightly preload the child with some fluid, normal saline. So dose bolus is given in the dose of 1 to 3 microgram per kg, and it can be ideally it should be given in the form of infusion in a dose of 0.5 to 2 microgram per kg per hour. And the advantage of dexmedetomidine is it preserves the epileptiform activity in brain. So it is preferred over propofol in epileptic patients for magnetoencephalography scans. So what is the ideal agent for pediatric MRI sedation? So the qualities should be rapid onset of action, predictable duration, easy titratability, rapid and consistent cessation of effects, multiple delivery options, a wide therapeutic window, minimal cardiorespiratory depression, minimal drug interaction, or should be minimally affected by renal or hepatic disease. So obviously, as we know that no one drug can match all these criteria. So the combination of the drugs, or the drugs as per the preference of the anesthesiologist, they are better when you are giving anesthesia. Some non-pharmacological sedation techniques can also be employed to reduce the doses of anesthetic agents like sleep deprivation, hypnosis, distraction, play therapy, music therapy, or you can allow the parent inside the MRI cabin. Now, the one technique, that is newborn babies and infants younger than 4 months will tend to sleep naturally if warm and recently fed. This one study was done on cardiac patients coming for MRI, and they just fed these babies and kept them warm, and they performed the MRI, and the success rate was around 85 to 90% just with this technique only, non-pharmacological technique only. So the smaller children, you can try this technique. Monitoring during sedation, this is very, very important. You should always monitor the vitals, but how to monitor, let us discuss. The ECG, the multipara monitor, which can be used inside the MRI room, the MRI compatible electrodes are available. So you can monitor the ECG with the use of these electrodes. But the thing is that these electrodes should be placed very closely over the chest. If you keep these electrodes wide apart, then it can, because of the electromagnetic fluctuations, it can lead to cutaneous burns. For monitoring SpO2, MRI compatible pulse oximeters are available. Here, the cables are not made up of metal, but they are these cables are fiber optic cables. For NIBP, the NIBP, routine NIBP can be used, but the connectors should be PVC cables. They should be made up of PVC material. For monitoring respiration, end-tidal CO2 should be monitored, but the mainstream CO2 monitor the analyzer cannot be used, so you should use a side stream analyzer. And for spontaneously breathing patient, non-intubated patient, you should always monitor the nasal end-tidal CO2. Visual monitoring of respiration is the most valuable monitoring when you are giving anesthesia in the MRI room. Keep the visual alarms on, and audible alarms may not be useful because the MRI room is a very noisy room, so audible alarms may not be useful in this scenario. So keep the visual alarms on. And palpation of the dorsalis pedis pulse. This you should always practice when you are giving the anesthesia for the kids in the MRI room, because this pulse is accessible to the anesthesiologist. And I usually prefer to stay inside besides the baby, inside the MRI cubicle. Coming to the choice between deep sedation or general anesthesia, or the giving anesthesia after intubating or after inserting the LMA. So usually it is recommended the younger children, the children younger than 1 year or sick patients, general anesthesia with endotracheal tube or LMA in situ is preferred. But obviously it depends on the experience of the anesthesiologist whether to intubate the child or not. The choice of drugs are also variable, and it also depends on the experience of the anesthesiologist. For general anesthesia, when the MRI compatible machines are not available, what we used to do is we used to keep the routine Boyle's machine outside the MRI room, and we used to extend the inspiratory tubing of Bain circuit or JR circuit, and we used to ventilate with this Bain circuit or JR circuit by sitting inside the MRI cubicle. If MRI compatible Boyle's machine is not available, this is this you can employ in your setup also. But or you can ventilate with ambu bag, and you can manage the patient on total intravenous anesthesia. General anesthesia, it can be either inhalation technique or total intravenous anesthesia. Induction outside the MRI room is also another one possibility. If you don't have MRI compatible laryngoscopes, then you can induce the patient outside the MRI room in a recovery room. You can intubate there, and you can shift the patient to the MRI room, and then you can manage there by ventilating the patient and using TIVA. So once the patient comes out of anesthesia, you should keep the patient under observation in recovery room. You should, when the child is well hydrated, awake, alert, and the vitals are stable, you can discharge the child safely. You must always give the instruction to the parents to accompany the child and avoid the tasks involving complex motor activity for 24 hours. So to conclude, need for sedation for MRI in pediatric patients is rapidly increasing. Ensuring safety of the pediatric patient should be your top priority. Now, if you are called for giving anesthesia for a child in MRI room, it does not mean that you should always say yes to the situations. If you feel the situation is not comfortable, you can always reject the child, or you can take help of a senior person or an experienced person. MRI room should be well equipped with MRI compatible devices and medications. Anesthesia provided should be competent in managing airway and resuscitation in pediatric patients. And selection of anesthesia drugs depends on age, weight of the child, comorbidities, and anesthesiologist's preference. Thank you for giving me this opportunity to present my views on this topic. I thank all the organizers, especially the Maharashtra State ISA chapter, for.
Okay, thank you, Dr. Bhattad. And now I request our chairpersons to give their expert comments and have some interaction with the speakers.
Balavaskar sir.
Madam, it is good.
First.
Madam.
Sir, you want to comment anything?
Okay.
Hello?
Yeah. So I congratulate both the speaker, Dr. Rashmi and Dr. C. Gopal. for a neat presentation in the sense they stuck to the timings. A lot of material is normally expected to be covered, but most important points, practically, how I do it. So that has been covered. So what it means is how they do it is one aspect, how much of other options are also available. They have also been discussed towards that. So that much is the presentation in terms of practicalities. And small comments are always there in the sense when Dr. Rashmi talked about the fiber optic bronchoscopy for foreign bodies. In general, in pediatric anesthesia, we'll be totally satisfied if we secure an IV lane and if we secure the airway. So this is the one which protects the patient through and protects ourselves. So what is highlighted is how the airway could be protected in these patients. And of course, the nil per oral instructions must be followed when the child is being taken up. And what is practically and technically important is the space between the bronchoscope that is going in and the mucosa. So whether it be the laryngeal mucosa and below the larynx towards the trachea. That's one important consideration because Dr. Rashmi did talk about problem during removal of the scope. So that's a very dangerous condition at that point of time. But to what extent the administration of hydrocortisone would help in preventing something like this is we are not sure. It's purely, it's, contextual.
Yeah.
But of course, we may start with the dexamethasone also, but it takes time to act. All of us know it takes time to act, but it is a definitive agent for reducing the edema per se. So that's one thing we can keep in mind. And monitoring aspect is, especially ETCO2 is a problem. So we can very well get SpO2 for the patient then. And if possible, if it is available, a transcutaneous carbon dioxide monitoring would be better. So it is academically, theoretically correct, but many of the setups would not have this transcutaneous option of carbon dioxide monitoring because we suspect hypercarbia, we anticipate hypercarbia in these patients. So that's the one thing. And Dr. Rashmi did talk about nitrous oxide because we also do. The foreign body have been doing it in the last 30 years when we had halothane those days. So when halothane was there, definitely we would try to avoid nitrous oxide. Not just the concentrations of air trapping and increase in the air that is there. It's because recovery will be delayed. So child would not wake up with nitrous oxide. It takes longer time to emerge out of the halothane anesthesia. Now that we have got the CO, that problem is avoided. And as long as we have control over the airway, we can still avoid nitrous oxide in this field. That's a good consideration. And I was only wondering about some adverse events related to spraying of the vocal cords. It's a small consideration. Definitely, I want Dr. Pradnya to take it up when she speaks next. And I was also wondering about the gold standard is like succinyl cooling being a gold standard even though. We are all happy to tell about repeat doses of succinyl choline whenever we want to ventilate and see that the oxygenation comes up. So practically, a problem of some desaturation. I was only wondering if we use an intermediate acting drug, a steroidal drug, would there be a scope for using Sugammadex? Yeah, so child can recover very fast, right? So we have seen, I have provisionally used in few patients, Sugammadex now. So it's such a rapid reversal and it is dose dependent. So if indeed we use instead of 2, we go to 4 or 8 milligrams also per kg, would we be very happy recovering the patient with a drug like, rocuronium and vecuronium? That's another aspect. And she was talking about other drugs. Now, for all applications, for our anesthesia discussions, we talk about dexmedetomidine. So left, right, and center. No route is left except the perrectal for dexmedetomidine. So maybe there could be scope for dexmedetomidine because Dr. Rashmi, I think you did not mention about dexmedetomidine. Could be possibly useful. Dr. Sagna Madam can contribute to this part also. So this much has been my observation. Thank you, Madam. Please, you can now take it on.
Okay. Thanks, sir, for all your comments. And first of all, I must thank, Maharashtra State Chapter, Dr. Saleh, Charutta, Samir, Balaji, and Avinash as well. I think these are two topics which are happening topics, and they're really good to discuss. They are evergreen topics
Sorry
to
to
discuss,
interrupt you,
but they are
ma'am. I
always
am muting
evolving.
all for the time
I think
being
I will
because
talk
there is an
about
echo.
first thing about a bronchoscopy. Rashmi, I had put some few comments, but before that, I would like to ask. You said about the rapid sequence induction. What is that rapid sequence in bronchoscopy?
Hello. Hello.
Yes, we can hear you.
Yeah. Rapid sequence I mentioned only in cases of a child who is coming in a stridor and who is side-nosed and who is like a full stomach. In that case, I do go for that rapid sequence induction, like propofol and with cricoid pressure and then the relaxant.
Madam, you are muted.
There is nothing like a rapid. Can you hear me?
Yes, yes, ma'am.
Yeah. So actually, when the child comes, as a full stomach, okay. So usually they are, sometimes if the emergency is not there, you can wait for the bronchoscopy. Unless there is a child is desaturated. If the child is desaturated, how to take the child and deep stomach can be deflated and can be taken.
Yes.
So the pressure of the cord in the children. Okay, that is the one thing. Second thing about the investigation, when you said X-ray chest, you always have to tell them, chest AP and lateral.
Yes.
Okay, indeed, that's very important. So whether the bronchoscopy, when the foreign body you can be visualized. Then
Pradna madam, your voice is too much breaking. There are messages continue.
If prolonged.
Pradna madam, can you hear me?
Hello.
Pradna madam, can you hear me? Your voice is breaking from your side.
I don't know now what is the audio because I can also not hear properly.
Probably she has joined from two devices. I think there is echo from side.
Echoing is there. Lot of echoing is there.
Okay, I can hear
Are you joined with two devices?
In the chat box, there are messages coming that your voice is not properly audible.
Hello, may I answer?
Now, can you hear me?
Yeah.
Yes.
Yeah. Okay. So now in this.
No.
Sorry to interrupt you, ma'am. Ma'am, I am for the time being muting all the faculties. So whoever is speaking, kindly mute yourself, right, sir and ma'am? I think that will work.
Okay. Yes.
Now, Pragya ma'am, from the particular device you want to unmute yourself, you just use that particular device. I think no further echoing will be there.
Hello. Can you hear me now?
Yes, ma'am.
Okay. So during that time, what happens? The child is quite hypoxic. Okay. So we don't know how much is the ETCO2. So sometimes it is better to have a, ABG and intraoperatively ETCO2. That's quite an important thing. Then you said the isoflurane. Okay, I think Dr. Bala Bhaskar also said previously we used to use a halothane, and that was quite a soothing bronchodilator. But I think isoflurane is not a very good idea, to do a bronchoscopy. CO is definitely better, I feel. Then investigation program. Yeah, that's I have said. Again, the foreign bodies, if you have a history of lithium battery, okay, that causes quite a lot of damage and it should be taken at the earliest. Again, the biological vegetatives like a chana and everything, these things are also has to be taken earlier. And I think if the child, as it is taking a too long time, we have said about the suxmethonium. But suppose if you are taking a long time and your suxmethonium dose is over, and then you keep on, giving a suxmethonium, that's not a good thing. I think the allotted dose of 5 milligram per kilo should be given. Then it should be switched over to the ATRA. Okay. Personally, usually I feel we do that. If ATRA is not there, if you have a rock uranium, that is the best, I feel. Okay. And as Dr. Balabhaskar said, suppose if you have given the Sugamades, if you have, you can just reverse it, for the long time. Yes, sir. One more thing, when they have a post-procedural cough, it is a severe cough most of the time. Okay. The child is quite a distress because we are introducing a rigid scope inside. So usually our institute, what we, our ENT surgeon does, he puts a, this cream, or steroid cream on the bronchoscope, and that can give a very soothing effect rather than, or you can give a IV lignocaine, so that the post-operative cough is not there. I think these few things are there in the bronchoscopy, and always it is happening. Your presence of mind has to be there. Anything can happen. It can go on the right bronchus, left bronchus, or it can get a choke up in the trachea. That's a very important thing. Okay, but nice presentation. Really nice presentation. Next, come to the MRI.
Thank you, ma'am.
MRI.
Can I answer a few?
In MRI.
Hello.
Yes, ma'am, you're audible.
Hello, Pradnya madam. Yeah, I personally don't use repeat dose of scoline with atropine. I never use, and I always use, if at all the procedure gets prolonged, I always give atracurium. And one more thing, Balabhaskar sir, I would like to answer. This, as the session was how I do it. So I didn't mention the dexmedetomidine because I personally have not used it. I'm planning to use it, but then I'll have to, use it in some first adult and older patients, and then I can think of using that. But just because I'm not using it, so I didn't mention that. And thank you so much for all the inputs.
Madam, we are muted, madam. Pradnya. Pradnya, madam, is muted.
Pradnya, madam, you are muted. Mute, Pradnya, madam.
Hello.
Now you are audible.
Now audible.
So I think personally it is, we do also give a dexmedetomidine. Previously it was not available, but nowadays. So in a chat box, somebody has mentioned regarding a Venturi. Okay, but I think now Venturi, it should be nearly outdated because you have a side arm for a ventilation, and for a smaller, very small child, if you are using the Venturi of 18 gauge, you can cause a pneumothorax. I think previously we used to use a Venturi, but nowadays we don't use that Venturi system. Okay. I think this is a person is from Nanded and he's quite comfortable. But I think for an older child it is okay, but not for the small children, because that's such a high PSI pressure of oxygen. The child may not be able to tolerate, or sometimes if the only one side bronchus is getting blocked, the other side is open. The other side can just burst and have a pneumothorax. That's a good thing. Okay, so then
there
talk
are
about
many,
the
actually,
MRI.
there are many studies also where they have compared this Venturi with the side arm ventilation. And when they compared the oxygen the oxygen concentrations which is being delivered, it was more with the side arm ventilation as compared to the Venturi. And when they measured the PaO2, even that was higher with the side arm ventilation. So if it's available and all, I think preferably we should go for the side arm ventilation. But then it's your personal choice. If you're comfortable with Venturi and with uneventful case management, I think even that is a good option.
Correct. I think one more thing I would like to tell you regarding this ventilation. When you say we have not talked about the thrive in this type of patients. Okay, thrive. The very high nasal oxygen flow. But since we have a side arm ventilation, it is quite a good thing to do about the ventilation process. When you said about this cardiac arrhythmias, I think when you see cardiac arrhythmias on the monitor, that is giving a very good sign that that the child can get arrested. The good that may be increasing the ATCO2 very high. So that has to be, taken care of. Anybody wants to comment on this? Otherwise, we'll next go with MRI. Want to comment, Charuta? Want to comment, Charuta?
Madam, I wanted to ask you. Hello, am I audible?
Yeah, you are audible,
Yeah.
Balaji.
Yes, madam. If a surgeon is very fast and you know that you are very much accustomed with the surgeon, we can do it on spontaneous ventilation with higher dose of propofol plus transtracheal 1 cc of lignocaine, so that irritability will be reduced of tracheobronchial tree, and this can be one of the method, provided surgeon should be a very fast. What do you think? Hello.
So you mean the on the spontaneous ventilation only with the blocks and the transtracheal?
With propofol, induce the child with propofol, give transtracheal 1 cc of xylocaine, maybe 1 cc or 1.5 cc. But at that time, patient should cough it. It is not an induction, very high dose initial only.
Right.
And later on, you just perform the bronchoscopy and take out the this foreign body.
Yeah. So this can be done. Actually, this can be done. But the only thing you never know when the child will cough out, and it's unpredictable. So while we are taking out the bronchoscope at the with the foreign body in it, and at the cause, if the child he coughs or if there is an increased airway resistance, then it can result in airway trauma or a bronchial rupture. So
and of course, there is a sharp foreign body. You have to give relaxant. I'm not talking about those foreign body.
Yeah.
Unless and until Balaji, the plan B is ready, we cannot see. We come from. I have a small comment on this. We come across the pediatric surgeons doing the foreign body removal. ENT surgeons are doing foreign body removal. At times, chest physicians are doing foreign body removal. Everybody is expertise. When we get stuck, actually take home message for all the audience we need to give it today. The foreign, when Rasmi commented on the patient coming in stridor, or patient long distance coming to the center, or the people who are going somewhere, going and doing the cases at nursing home level to remove the foreign body when the equipments are not available, and the patient coming in stridor with some of the event of this cyanosis, that moment of time, unless until you sometimes it is an emergency, sometimes you have a time to plan everything. That moment of time, plan A, plan B, everything has to be ready. I agree with Rasmi and whatever Pradnya madam is saying.
Yeah, I am also 100% agree with their method. Whatever they have said is the most safest method. But this can be another method.
One more
in selected cases.
Yeah.
Balaji,
one more thing.
There are very few surgeons who would be expert enough to do this. That is the main limitation.
There is nothing like expert and all. I wanted to know from Rasmi and all the experts, Bala and this thing, Pradnya. When the foreign body, sometimes we never know what foreign body is there. With the clinical, this thing, we suspect that there is a foreign body. Say, for example, coconut, piece of coconut. Say, for example, groundnut, this thing, partial groundnut, this thing. Such type of foreign bodies means I have come across a number of children when we have repeated the anesthesia for second time, third time, by all the expert this thing, ENT surgeons and pediatric surgeons. In one sitting, they could not remove it because the foreign body doesn't come into the grip of that forceps, or it comes in the small piecemeals. How long we should give anesthesia? And it's a failure. One surgeon, second surgeon, third surgeon has come into play, and then it has come out. All the expert people, what I mean to say, this take-home message for such events, sometimes which you don't know, metals and all, you know that this is some metal and the size and everything you can make out, but these things you cannot make out at times. You know that foreign body. I have come across the kishmish as a foreign body. Now, how do you manage this?
Yes.
It comes a micro space only in the forceps. And you go on doing and doing and doing and you ventilate all those things. We have started with Negas bronchos, so that time Venturi and all. I agree with that. That's now we have at least that safety is there where the ventilating this thing is there. No, all the experts and Rasmi, you can comment on this.
Yeah, I would say, sir,
Yes,
they are
the
quite frequent, sir. Yeah, sorry, madam. No, these instances which sir has told is even now happening continuously with the
Yeah.
most experienced ENT surgeons, experienced pediatric surgeons also. So these instances are quite common. The endpoint is only just our decision. Basically, how frequently and to what extent the child desaturates is one thing. So sometimes we have to control the surgeons, basically, because that much of trauma around the larynx and into the trachea is definitely a risk, and we sometimes need to intubate the child and leave it on elective ventilation.
Correct.
Correct. The saturation. So safety first, basically in this regard, as evidenced by desaturation and improvement of the patient and the tight chest. It's very difficult to reverse the tight chest. So we may need to paralyze some of these children in the post-operative period and ventilate electively. And I don't think the type of ventilation will help in such cases. The endpoint would be a very wise and sane decision to stop, revisit the patient after the child recovers with additional expert help. And if it is not possible, we should accept defeat and again send it to probably a higher center also. That's my opinion.
I have come across the child going to the typical laryngeal edema where it was just difficult to maintain the saturation post procedure.
Yes, I think that is the most important thing. Okay, because what happens? Because when you are doing it repeatedly, these procedures, okay, and the digit scope is going again and again, that causes children can caught laryngeal edema very fast. So in such cases, I think we have to terminate sometimes, the procedure, okay, and we can do the chest scoping later on. Okay, that is also okay. And if you think that, if the child is going to have, laryngeal edema post-operatively, that child has to be observed in the IPCU, cannot be sent in the ward. Because that's a quite risky, because post-operatively that child can choke up, that foreign body can come in the trachea and child can choke up. So that child has to be, monitored very carefully. This can happen. That's what I said. The foreign body is a, adrenaline draining, procedure for the anesthesiologist. However, expert you are as a surgeon also and as an anesthesiologist also, your presence of mind has to be there. What to do next? It is not like a, recipe for a bronchoscopy. Anything can happen, and for that you have to be ready for that. That's a very important thing. I think the any take-home message. No, I wanted to talk about the Balaji. When you said about the propofol and transtracheal. So I don't know how many people will be able to give a transtracheal, lignocaine, when very small children, like a 2-year-old child. Okay, that is the expert really requires the expertise to put the trans. And second thing, if you give only propofol, the child is apneic. And child is not doing spontaneously. If the child is, having very low respiratory rate, the CO2 keeps on building. So that's not a very good, you in a bronchoscopy, you require a very good depth of anesthesia at the time of the removal. And after the removal, you require all the reflexes should be present. Okay. So the best is to give a propofol, medas, and some, dose of ketamine and, relaxant. So the child is post-operatively, immediately they are out with a good reflexes. So that the child may not aspirate. So if you keep on giving a, spontaneously about the propofol, the child may not be able to breathe post-operatively. You want all the child awake and with good reflexes. That is the major plus in bronchoscopy. Personally, I think, because after doing 30 years of bronchoscopies.
Yeah. Okay, we'll proceed.
I would like to add. Hello. Yeah, one thing I would like to add is the adrenaline nebulization once the foreign body is out or after the extubation. Routinely,
Yes.
I routinely follow. I usually give the adrenal nebulization to reduce the airway edema in such patients. It is very
Yeah, adrenaline and even a Budecort you can give.
Yeah.
Budecort also will have a stabilizing effect, or mix you can give post-operatively.
Yeah.
That also gives a very comfortable this thing.
Yes.
Okay, so shall we move to next?
Yes, madam. Let us move
So
to the
regarding
MRI topic.
MRI is also a very good topic, happening topic in the pediatric anesthesia, and most of us get really scared in unit. So very nice presentation, Dr. Bhatted, but the only thing you forgot to mention few things about these things. Whenever practitioners they are going, I'm not talking about the children's hospital. The children's hospital are well equipped. Okay, they have a recovery and everything. But when they are occasionally when you are giving in, the most of the MRI centers may not have a recovery. Okay, they just keep the child outside. They may not have oxygen, and as you said, this is most neglected part. Actually, it should not be neglected by anyone, especially for the anesthesiologist. Okay, so the pre-operative, when you say the pre-operative, we don't have time. No, don't do that. So if you are going to do that MRI suit very frequently, tell that radiologist to fill up that form. You can have the form and see whether they are NBM and if you have a comorbidities. Like especially like a cardiac patient, he can give you a lot of trouble. Otherwise, it is okay. Then you said about the chloral hydrate. Chloral hydrate, as a pediatric anesthesiologist, we don't give. It is very useless drug, absolutely. Okay. So because when they are coming for the MRI, we don't know their liver and the renal condition because all the investigations are not done. So we want to give a very short acting drugs and the child has to be awake. These are the most of the time it is like like a daycare surgeries.
Yes,
And one more thing, hypothermia is important.
I wanted to tell that chloral hydrate is very popularly given by the pediatricians and radiologists, but anesthesiologists usually
but what happens if the child does not get sedated? Okay, then they call the anesthetist. The anesthetist gives the midazolam, propofol, and the child takes a very long time recovery.
Yeah.
That's the thing.
Yes, ma'am.
I think we have to give a time for the third speaker.
Yeah. So, Balabhaskar sir, do you have any comment or we go ahead to the next topic?
Yeah, please go ahead.
Yeah.
Madam has discussed
Actually, MRI should require more time to discuss.
Yeah. There is. Even the next topic is very attractive.
Pradna, there are a lot of people waiting for that regional anesthesia.
Yeah,
which
I know, that is why I have stopped
favorite topic of yours. So
I know, yes.
there are
yes.
question answers are also there at the end.
Absolutely. Yes.
Sure, please.
Yeah, question answers are also there. There's a lot of questions.
Yeah.
Yes.
So let us begin with the next topic, that is regional anesthesia in pediatric patients. And I request Dr. Vineet to begin his deliberation.
Can I share the screen?
Yeah, sure.
Is it seen? Am I audible?
Yes.
Yeah. Good evening, all. Many thanks for giving me an opportunity to present indeed the most talked about and the most fascinating topic ever in pediatric anesthesia, the topic of regional anesthesia in pediatric patients. Before we begin, I would like to highlight that all the permissions necessary for taking the videos and photos of the patients and the use for academic purpose has been taken, and I do not receive any funding for demonstrating any lectures. Greetings from Paediatric Hospital for Children, Mumbai. Fortunate enough to be a part of this teaching hospital of worldwide repute with the largest neonatal intensive care unit in the West Zone. We also do run fellowship programs in pediatric anesthesia, as we all know, of 1 year with an intake of 10 seats, as well as we have a lot of observer posts. So it's a very merry triad, isn't it, when it comes to pediatric anesthesia? We're a very merry triad of scared souls, the child, the parent, the anesthesiologist, each having their subjective fears. The child is scared of doctors, masked people. The parents are really apprehensive and worried about their child. Will the child wake up from anesthesia? Will the child have pain? And the anesthesiologist, of course, how, what, how much, what's my anesthesia plan, how do I go ahead, what are the post-operative complications. Well, to settle this chaos, let's stick to these golden rules which are there on the screen. First and foremost, do no
Hello,
harm
Vinny.
is the dictum which we always. Am
Vinny,
I audible?
yeah, your slides are not moving.
Pardon me?
Your slides are not moving.
Okay.
Okay.
Where am I stuck? May I know? Like which slide?
The golden rules.
Okay. So to settle the chaos of the apprehension amongst the parents and the anesthesiologist and the patient, let's follow these golden rules when it comes to pediatric anesthesia. Firstly, do no harm. Please understand that children are not small adults, hence do not extrapolate adult data into pediatric practice. Let's practice evidence-based in this era of modern pediatric anesthesia. Understand that baby do feel pain, hence treat it meticulously. Don't be too apprehensive about the subject, but also at the same time, don't be too overconfident. That brings us to the whys of regionals in modern pediatric anesthesia. Regionals definitely provide superior analgesia. It reduces the minimum alveolar concentration and hence the risk of neurotoxicity. It provides a hemodynamically stable patient, obtains the stress response to surgeries. It reduces the blood loss, improves GI function, and definitely reduces the need for post-operative ventilation. With so many positives, one should naturally ponder if it is really safe enough to practice regional anesthesia. Is regional anesthesia safe in children? Well, the reported rate of complications are only 0.12% as per the audits and the PRAN registry, which is a pediatric regional anesthesia network registry. Regional anesthesia in children have the potential to enhance positive outcomes, decrease surgical stress, and definitely reduce healthcare costs. It has always been the cornerstone of opioid-free anesthesia. And of course, as we all know, the application of ultrasound. Ultrasound has changed the name of the game. It has increased the safety by providing a new vision to an otherwise blind technique or a blind block. Which brings us to certain differences and implications for pediatric regional anesthesia. Certain implications we need to know due to the differences in anatomy and physiology of a child. Anatomically, they have developing structures which are close-knit, the nerves, the vessels, the adipose tissue. There is more chances of injury to the nerves. There is incomplete myelination. Prolonged motor blockade is a possibility with that. When it comes to the spinal contents, always remember in neonates and in infants, everything ends lower than the adults. So basically, the dural sac will end at S4 as compared to S2 at adults. The intercrystal line will be at L5 S1 as in comparison to L4 L5 in adults. The spinal cord will terminate lower down at L3 than in adults. Hence, we should be very cautious while we are doing a caudal block or a spinal anesthetic. There is always a risk of dural puncture while doing a caudal block, and the spinal anesthetic should be performed preferably below the level of L4. Coming to the physiological differences, children have a very high cardiac output. They have immature hepatic metabolism, and hence there is an increased risk of drug toxicity as well as accumulation when it comes to continuous infusions. One good thing, children usually less than 8 years of age are less prone to hypotension after neuroaxial blockade. That is owing to the lumbar orthosympathetic component is poorly represented in children. So what are the indications for pediatric regional anesthesia? Definitely managing post-operative pain, treating cancer and beyond, that is non-cancerous pain conditions. It has been an integral part of ERAS, enhanced recovery protocols in many institutes. It provides adequate management of acute pain. Hence, we can prevent the worst outcome, that is prevention of transition to the chronic pain. What are the contraindications? Contraindications can be absolute, they can be relative. Absolute contraindications include patient or parent refusal, surely, and local anesthetic allergy, a documented local anesthetic allergy. Relative contraindications will include infection at the needle insertion site, coagulopathy, sepsis, septicemia, and pre-existing neurological deficits. In the slides to proceed, let's look at the blocks which can be done in pediatric anesthesia, pediatric regional anesthesia. We can broadly classify or divide these blocks into everyday blocks, the blocks which we practice on a daily basis, and most of the daycare procedures, especially in non-pediatric hospitals or other tertiary care centers, can be done under these blocks. They are namely the caudal, the epidural, the axillary approach to the brachial plexus, penile and ring blocks for circumcisions, tap blocks for abdominal surgeries, and the so-called hernia blocks, ilioinguinal, iliohypogastric blocks for inguinal herniatomies. Coming to the advanced blocks in pediatric anesthesia, these are the advanced blocks. They are usually the anterolateral or the posterolateral truncal blocks. It has a long learning curve, lots of hands-on practices required, and it will be discussed maybe in the next presentation. So let's look into the routinely used regional anesthesia. Well, caudal epidural has always been the big boss of pediatric regional anesthesia, a volume-based block whereby Hermitage formula is used to calculate the volume of the drug. The picture on the left side denotes the landmarks for the caudal epidural, which is the posterior superior iliac spine
Dr.
and the
Vinay,
sacral. Yes,
Dr.
ma'am.
Vinay, your slides are lagging behind. Just go to the next slide if you can, because we are not. Now the caudal has come. Yeah. Please go ahead.
Okay.
Yeah.
Okay, so as I said, caudal epidural has always been the big boss of pediatric regional anesthesia. It's a volume-based block. It can Armitage formula, which is on the screen, is used to calculate the dosage of caudal epidurals. The confirmation of caudal epidurals is usually historically it was done using the so-called the swoosh test and the whoosh test, where the operator performing the caudal block injects saline, and the another operator holds his stethoscope at the desired dermatomal level and could hear a whoosh if there was a air injected, or swoosh if there was water injected. It's now largely replaced by a sonography probe. The ultrasonography has replaced the stethoscope, and we can see real-time sag or lag of the anteradiural complexes. Well, in this video, I would like to demonstrate two frequently used techniques for caudal block. One is the caudal block with landmark technique, and the other is a sonography guided technique. So let's see the first technique, whereby the needle entry is at an angle of 45 degrees, after which a Guebet is felt, then the needle angle is dropped and the needle is advanced further. In the next video, which is a USG guided block, here the probe, in the picture which we can see, the probe is positioned initially at the entry point, and then it is fine-tuned to the dermatomal level of interest. As the drug reaches the desired level, as we see it now.
Vinay,
Yes, ma'am.
Yes, your slide is not moving. You go to next slide now. Nothing is visible actually. Yeah.
Is it visible now, ma'am?
Yes.
So here you can see the sag of fall of the dura, anterior dural complex, as the drug enters the caudal epidural space. This is confirmation with using an ultrasonography. Am I in sync with the slides, if I may know? Hello?
No, next slide.
Okay. So the local anesthetics which are frequently used in caudal blocks are 2% lignocaine with or without adrenaline, 0.5% bupivacaine or 0.2% ropivacaine. We have an array of additives which we can add, which includes additives like morphine, ketamine, midazolam. The FDA approved as of now, and which is followed in our institution, is clonidine, 1 to 2 micrograms per kilograms. The speed of injection while giving a caudal block should be between 60 to 90 seconds. Complications. What are complications? Out of all the complications, the most dreaded one is toxicity. Toxicity denotes wrong dose, wrong drug, wrong space. Try to minimize the avoidable complications, like check the labels before aspirating, check the aspirations, check the expiry dates, and so on and so forth. Coming to the topic of epidural.
Vinit, can you go to full screen? Full screen mode.
What's happening to the presentation?
It's normal to me.
ClearNet person, can you explain? Rituparna, can you explain what is happening to the presentation? We can't see, can't hear.
Ma'am, it's a problem from the speaker's end, ma'am.
Okay.
Dr. Vinit, kindly start sharing your screen once.
Is it seen now?
Not yet. It's getting connected. Yes.
Yes, sir, you are connected now.
Yes, yes.
Is it seen?
Epidurals is the slide that is seen.
Was the caudal block landmark technique and USG guided seen, if I may know?
Actually, the video could not be seen when you were talking. It played, but it
Dr. Vinit's bandwidth is low. Dr. Vinit, I request you to sit in a proper place where the network bandwidth is proper.
Okay, I'm sorry. Just give me 2 minutes. I'll change the network. I'm so sorry.
Dr. Vinit, shall I share
sharing the screen now.
From Dr. Vinit, you can share it with me. I can share it from my end, sir.
I'm sharing the screen now.
Okay, sir. No issue.
Yeah. Full screen.
Am I seeing now?
Yes, sir.
Yeah. So I'll just run through the caudal videos if I can. The previous ones.
Yeah, go the previous one. Yeah.
So there you could see a landmark technique of giving a caudal block and confirmation with a sonography probe if it's feasible. You could see the sagging of the anterior dural complexes when the drug reaches the desired dermatomal level. With respect to epidurals, the most commonly placed is the lumbar epidural. Less commonly placed is a thoracic because it's largely been replaced by the paravertebral and erector spinae blocks. Now, there's always been a controversy which method to use, loss of resistance to saline or loss of resistance to air. According to the recommendations, a dual method is recommended. Loss of resistance to saline is the method which we follow at Wadia Children's Hospital. Whichever method is used, it actually depends basically on the operator's feasibility, and the more they use to one technique, the better it is. But always remember, whenever you use air, try to minimize the volume to less than 1 ml while demonstrating a loss of resistance. With respect to giving a test dose, also it's operator variable. We would recommend local anesthetics should be injected very slowly. And while you do that, you should always keep a watch on the ECG, especially the STT morphologies. When it comes to epidural catheters needles, we usually use 18 gauge or a 20 gauge shorter needle or Tuhi needle, which is 5 centimeters. So in children less than 1 year, a 20 gauge epidural with a 22 gauge catheter is preferred. Children more than 1 year, we can use an 18 gauge needle with a 20 gauge catheter. Here, as you see in the picture, we can see a pediatric epidural set, which has an 18 gauge Tuhi needle. Also, it has a 19 gauge catheter, a lower lock connector, and a loss of resistance syringe. How do we determine depth of the epidural space from the skin? Idealistic approach would be a pre-procedural ultrasound assessment, which can, as shown in the picture, can detect the depth of the epidural from the skin. The most commonly used formula, however, gives a rough estimate of the actual depth of the epidural from the skin is 1 kg body weight. So, for example, if you have a 10 kg child, it will be approximately at 1 centimeter from the skin. Definitely, it's a guide to placement of epidurals. It's not a hard and fast rules, these formulas. Pediatric epidural dosing, out of all the dosings and the initial bolus and infusion limits, the most commonly used drugs are bupivacaine and ropivacaine. Bupivacaine can be used as an initial bolus up to 3 mg per kg and as a continuous infusion of 0.065 to 0.1%. Pediatric spinal anesthesia. Pediatric spinal anesthesia, in my view, has very lesser indications these days. The depth of the lumbar puncture also can be based on a formula, and the formula for dose calculation of heavy bupivacaine is as follows. When you compare a pediatric spine and an adult spine, spinals are more denser and wear off quicker in pediatric. Hence, post-operative analgesia is also questionable. This might be attributed to the greater CSF volumes, which we can see as it's 4 ml per kg in a newborn as compared to 2 ml per kg in adults. Also, in children, the nerves and the myelination is lesser. The nerves are thinner, the myelination is less. Hence, we get an instant motor blockade, but it wears off quickly as well. As due to the as the curves are not developed, the secondary and primary curves are not developed, there are more chances of complications with respect to pediatric anesthesia and to pediatric spinals. That is, a high spinal can occur more easily. The spinal needles which can be used are short needles. They allow more precision. They have smaller dead space. They will bend rather than break in case of an eventuality. They better appreciate the tissue resistance. There are lesser chances of incomplete drug injection. Most commonly used spinal needles are 25 gauge and 29 gauge. 22 gauge, the black color coded needle, is usually used in the IPCUs for doing lumbar punctures or something like that. I think so. This is almost the only indication or the most common indication for performing a subarachnoid block, which is ex-preterm infants. Especially, they usually will come for lower abdominal surgeries or lower extremity surgeries. Subarachnoid block is a good option in children less than 60 weeks of post-conceptual age, where surgeries last under 90 minutes. As we all know, ex-preterms have an increased incidence of apnea. It increases to almost 50% when the age is less than 48 weeks post-conceptional age. So subarachnoid block helps reduce the incidence of apnea, bradycardia, desaturation, and definitely post-operative ventilatory requirements. Coming to the additives in regional anesthesia, why do we need additives? Firstly, additives prolong the duration of analgesic effect. It allows smooth emergence and a calm recovery. It reduces the incidence of emergence delirium and shivering. It gives a child a very comfortable early post-operative period, and hence also helps in ERAS, that is early discharge from the hospitals. Well, spoiled for choices, aren't we? So many of them. We have dexmedetomidine, fentanyl, ketamine, dexamethasone. What to choose? Which one is better? What do we think? So, as I had told in the initial slides, the golden rules, let's practice evidence-based. This article from the 2022 RAPM solves the question. FDA approved for pediatric regional anesthesia is clonidine and preservative-free morphine, out of which most commonly used drug is clonidine in a dose of 1 to 2 microgram per kilogram for central neuroaxis as well as peripheral nerves. In the next few slides, let's have an overview of some everyday blocks in routine practice. I've tried to gather it together in form of a small videos. Coming to the ilioinguinal iliohypogastric block. It is commonly known as hernia blocks. Most of the daycare procedures in pediatric anesthesia, where application of pediatric regional anesthesia is essential, are usually inguinal herniotomies. The picture on the left, it shows a landmark for needle insertion. The video will demonstrate how do we do the block using landmark technique. So landmark technique is a good practice for this block. It gives quite consistent results. Of course, as I said, all blocks can be done using landmark techniques or by using PNS or under ultrasound, whatever is available. Main thing is to do it safely. Coming to circumcisions, again, one of the most commonly seen procedures in pediatric population. Penile and a ring block, as depicted in the figure. The pic on the left side shows the cross-sectional anatomy. The nerve of interest to us is the dorsal penile nerve. The injection site is as shown at the root of the penis. We use usually hypodermic needles. So I would like to highlight here is a penile and a ring block. The ventral surface is blocked with a subcutaneous injection of local anesthetic. Please remember the local anesthetic used is always free of adrenaline. It's always plain drugs, no adrenaline used in it. Coming to the tap block and the subcoastal tap block, these blocks again can be done landmark guided or with using an ultrasound. It is generally used for abdominal surgeries. The picture on the left depicts ultrasound images of the layers which can be seen starting from the external oblique, the internal oblique, and the transversus abdominis. The drug is deposited between the internal oblique and the transversus abdominis. The video is a presentation of subcoastal tap block. Mainly, subcoastal tap blocks are usually used for hepatobiliary surgeries, cholecystectomies, Kasai's procedures. It starts with the ergonomics of the blocks as shown in the video, and the drug spread will be seen between the rectus abdominis and the transversus abdominis. I'll play the video now. There you see the drug spread. Coming to the upper limb blocks, brachial plexus blocks can be given at interscalene, supraclavicular, infraclavicular, axillary. Axillary approach to brachial plexus is performed for procedures usually below the elbow. The common procedures for which these patients come for is either supracondylar fracture fixations or, as shown in the video, a syndactyly release or some deformations of the upper extremity. The video shows a patient which is posted for a syndactyly release. As we can see in the video, we'll be showing the positioning for the axillary block, the needle insertion technique, the continuous palpation of the axillary artery, and the movement of the needle along with the pulsations. I'll play the video now. This is a patient 4-month-old who had come and reconstruction. Basically, we used an ultrasound guided axillary block in this patient. I'll play the video. So the drug is deposited around the axillary artery. In the video, we could see the median node followed by the ulnar distribution of the drug. And the key to it is slow and careful advancement of the needle so as not to cause any harm. Again, another approach to brachial plexus is the infraclavicular approach. Landmarks will be shown in the video. The thumb of the non-dominant hand will be kept on the coracoid process, and the twitches will be seen as we enter with the needle. Coming to the lower limb blocks, the femorosciatic nerve block is one of good modalities. Here we will be showing a 2-year-old child whereby the femorosciatic block was given with USG and PNS guided. Note that it was a popliteal approach to the sciatic nerve in supine position, so we didn't have to change the position of the child. In the video, you might see clips of the femoral nerve stimulated, which can be the patellar tendon reflex, and the plantar flexion for the sciatic nerve, and the drug deposition will be seen in real time. Coming to the miscellaneous blocks, the head, neck, face, it can be blocked. We get a lot of patients with cleft lip and cleft palate repair. The infraorbital nerve block, which can be given both transcutaneously and transorally, are common blocks which are used. Small volume, a 0.5 to 1 ml of 0.25% bupivacaine or 0.2% propionate is usually enough for these blocks. It gives good post-operative analgesia. Coming to the ophthalmic blocks and the dental blocks. Now, dental blocks are usually done for full mouth rehab, dental rehab patients. We usually have patients for full mouth dental rehab who are syndromic, or patients who have cerebral palsy who come for full mouth dental rehabilitations. We do it in the general anesthesia with nasotracheal intubation, and commonly given block there is inferior alveolar nerve block. With respect to ophthalmic blocks, they are preferred in older children. Smaller children, as per even the pediatric ophthalmologists, they are a bit apprehensive of blocking the globes, because the volume of globe which occupies the orbit is quite more, and there is a risk of perforation of the eyeball. Coming to the blocks of the cranial blocks usually in major surgeries like craniosynostosis, the surgeon injects a volume of local anesthetic under vision. It also helps in post-operative, intra and post-operative analgesia to a huge extent. Coming to the general dosing for peripheral nerves, generally it is in the range of 0.2 to 0.3 ml per kg for most of the blocks. Here of the sciatic nerve, it's a thick nerve. We can go up to a volume of 20 ml in the sciatic and lumbar plexuses, and 0.5 ml per kg can also be used. Last but not the least, the most dreadful complication of regional anesthesia. It is a rare but potentially fatal event when it happens in pediatric age group. Early recognition is important. Recognition in pediatric is very dicey because all our blocks and are done under general anesthesia. So the CNS symptoms are usually masked. The severe symptoms and findings should be noted. Basically, monitoring should be very apt. What's the treatment? The treatment is intralipid 20%. It's the way out along with resuscitative measures. The dosing guidelines for pediatric local anesthetic toxicity lipid resuscitation is you have to administer 1 ml per kg of 20% lipid emulsion IV. You can repeat the dose every 3 to 5 minutes to a maximum total dose of 10 ml per kg. Maintenance infusion doses are 0.25 ml per kg until circulation is restored. The controversial and a topic which raises many eyebrows actually, compartment syndrome and regional anesthesia. Many a times you are called by the orthopedic surgeons for a supracondylar fracture fixation, and the orthopedic surgeon will tell you, nahi, isko block nahi dena hai. And as an anesthesiologist, everybody of us will be dejected, of course. But let's not take it to that level. Let's follow the current best practice guidelines. Basically, it's a teamwork. Hence, we have to speak to the orthopedician and know his concerns, why he doesn't want us to give a block. What we can do is we can divide these patients into low-risk categories and high-risk categories. High-risk categories usually will have some amount of discoloration around the elbow, or there will be some old cases of supracondylar fractures. So what we can do is reduce the local anesthetic dose. We can reduce the concentration, for example, to 0.1% from 0.25%. I would not use adjuvants in these cases, as I wouldn't want a very much prolonged effect of the block, especially the motor blockade. As I discussed, high-risk patients should be adequately reviewed by the acute pain service team and the surgical team. Monitor for compartment syndrome in the post-operative period. Even if you have reduced the dose of local anesthetic, you have given lesser volume, please monitor the patients in the post-operative period. In case the surgeon feels that the patient might be developing a compartment syndrome, definitely do the monitoring which is required. Same goes to the sciatic catheters for high-risk populations. Well, having said everything, as always, as discussed earlier, the indispensables of safe pediatric anesthesia practice, the airway and the intravenous access. A good flowing IV, a secure airway will take you a long way when it comes to pediatric patients. Adult regional anesthesia and pediatric anesthesia are totally different. Adults are usually done awake. Pediatric regional anesthesia, you have to be good in managing the airway and the IVs. Kids give us much more, you know, they give back much more than we ask for. I'll show you a video. You know, it's very gratifying to see a kid dance his way through in the OR. He had actually come for a redo surgery, and we had not given an ounce of pre-medication to the patient. So all they need is smile and care. Let's make them sail smoothly through the perioperative period. So with all passion, compassion, a whole lot of gratitude, let's make the pediatric world safer and pain-free. Thank you very much, and I apologize for the interruptions in between. Thank you.
Dr. Balabhasar?
Yeah, that's as Dr. Veer was telling at the end, it was a great presentation, but interrupted by technicalities. So
I'm so sorry for that,
sir. Yeah. Otherwise, very nice presentation.
Thank you, sir.
As he says again, we should be cautious about the usual things. Be ready for emergency intervention, airway intervention, something related to the high level of block. And I just would also be happy to know from you about the risk of systemic toxicity in pediatric age group. And how do we counter it? A little bit about the lipid emulsions. What is the experience per se overall now in the field related to reversing the toxicity with lipid emulsion in pediatric age group? That risk is always there, as you said. Can you please explain a bit?
So luckily, we have been very fortunate not to have any incidences of local anesthetic systemic toxicity. As I said, it's not only intralipid, it starts from the word go, like when you start preparing for a block. As I said, you aspirate your drugs, check your labels, check your expiries, check the weight of the patient, calculate the drug dosages. It's a very common habit since we are a fellowship teaching hospital. It's a very common habit for us to make a plan of anesthesia and just put it near on the wall or put it near the anesthesia machine so that everybody knows what dose of a local anesthetic is going to the child, or how much additives are we adding, if at all we are adding the local anesthetic to the child. Also, the usual principles: aspirate your drugs, check the labels. We have intralipid stored in our hospital. Luckily, we haven't had such incidences of like we have to use it at least till the time I am here. The only thing which I have definitely heard while I was doing all the training and all those things is it's difficult to resuscitate these patients, and timely interventions is required, especially when you're using drugs like bupivacaine more than ropivacaine. Ropivacaine has a more CNS to CVS toxicity ratio as compared to bupivacaine. But having said that, it's very difficult to take the resuscitative measures and treat these patients who undergo a cardiac arrest or something like that. Definitely a PICU backup should always be present. all the resuscitative airway equipments, airway, everything should be available. And we should always closely monitor the child even after resuscitation is done.
Yeah. So one of the mistakes we also do, I mean, there's a tendency for the beginners, basically, because we have to give some sedation or anesthesia before we initiate the block in majority of pediatric patients. So some of them we are able to manage, even 5-6 years old, we can talk over to the patient and see that we can also keep them awake.
Correct.
So, but majority of them are under some ketamine anesthesia or some fentanyl with or ketofol for the patients. It's difficult to track about the intravascular placement also or toxicity per se. So there is a risk of not, because child is not awake. The usual symptoms like restlessness is not there, and very young children cannot complain about subjective symptoms and signs. This is one of the limitations with respect to detection of anything unfortunate, including intravascular injection or toxic. And another thing I would like to stress is, as you said, for caudal we use hypodermic needles. Basically, a very unusual discussion about some epidermal cells being taken in because there is no stilate per se. So these are all again, I think, theoretical discussions. I think Dr. Prajna will also talk about it later. And availability of the pediatric sized spinal needles. So again, we had problems with respect to these needles in the previous years. So fortunately, nowadays we have got the suitable needles which are available. We were using the adult needles and trying to, it's purely out of experience, we were able to track the space. And now we are, again, we are fortunate to have the pediatric sized needles also for all the blocks. That advantage is there. And what about the peripheral nerve stimulator utility? I think there was no mention of this in your presentation. Purely ultrasound.
So peripheral nerve stimulator, definitely it's a very much an integral part of pediatric regional anesthesia. I feel especially in patients who are syndromic patients or who have limb deformities, the upper limb deformities, lower limb deformities. In them, the anatomy might also vary. So we recently had a case where the patient was a radial club hand patient, and we had taken him for a reconstructive surgery. We scanned him using the sonography, but the subclavian perivascular brachial plexus couldn't be scanned adequately. So there we definitely deploy a PNS guided modality as well to confirm with the twitches. Hence, I feel a dual method of PNS and ultrasonography is the best and the safest as of now. That's what I feel.
Yeah. So, and most commonly performed is, of course, the caudal epidural. The majority of us in the practice. Is there anything related to the long-term sequelae related to the caudal epidural? We all feel it is very safe to give. Do you think there is something related to the long-term adverse events?
It is a safe block and safe answer. With caudal epidural, the long-term, if the patients are having any midline clefts or they are having any tough hair, it actually becomes a contraindication to give a caudal epidural, even USG guided. But while counseling, we do counsel that there might be some neurological deficits which might be unforeseen. Till date, there have been no complications per se which are life-threatening or making the patient morbid. With the caudal epidural, it's relatively safe. We enter at a very lower level. Even the chances after a dural puncture into getting nerve damage or something like that is very less. Hence, it's one of the safest blocks, and it is one of the multi-purpose blocks in pediatric regional anesthesia.
And one final question is, which I frequently find in similar discussions in presentations, especially from private practitioners who speak about simultaneously, you have caudal epidural being given first, and in the same setting, give a spinal anesthesia, because the catheter technique is only used majority in institutions only. So do you think it is safe in terms of dosage to administer caudal epidural in terms of a particular drug, bupivacaine, for example, and spinal anesthesia with bupivacaine in the same patient, in the same setting?
So in my opinion, as I had posted in the slides also, spinal anesthesia in children, it gives a very dense and early motor blockade. But as we saw in the indications, which are evidence-based, it's usually used for surgeries less than 90 minutes. So as I said, I don't think so we should extrapolate adult data into pediatric. combined spinal epidural doesn't work in pediatric. Caudal is an amazing block. It's a very safe block. It will also provide post-operative analgesia. You can adjust your dosages accordingly. The motor blockade won't be there post-surgery. So I feel if I am wrong, added advantage of spinal would be just in such cases would be just a denser block. We can wait up for around 5 to 10 minutes, and the same thing we will get with the caudal blocks.
Yeah. So the secretary is just waiting for the drug to order, then allow the surgeon to proceed. Yeah, that's well said. The people are asking about the dosage, the toxic dose are reached or not. This is a frequent discussion in the private practitioners group. That's why I asked this question. Yes, madam.
Yeah, it's quite a really interesting topic and very good, close to my heart. We can talk, hours together for, but just few comments on this. Regarding the catheters, especially like in a neonatal catheter, if you put the caudal catheters, neonate can have a cumulative toxicity. So when you are putting a catheter and giving the post-op infusions, you have to be really very careful in the neonates. Okay. So again, regarding the toxicity in my previous, personally I have seen a local anesthesia toxicity, CNS toxicity, especially in a caudal and very premature children's. Okay, because the vascularity, the local anesthetic absorption is very fast through the vascular caudal space, and that can really have a contraction of the hand. Because in general anesthesia they may not have a convulsions as such because of general, but you can see their hands having like this, very small children. So immediately you should look out for if any bradycardia, hypotension, and this is very strange switching movement. So immediately you should come to know that there is a local anesthesia toxicity. Older children, regarding the CSC, you can use older children like 12-year-old, that can be done. But usually when lumbar epidural is so good, or caudal epidural, especially lumbar in older children, we don't like to give a combined. Either you can give a spinal for short procedures, or for a long procedures you can give a epidural with the catheters. That's I think one more person he said whether to use a dexmedetomidine. Of course, you can use a dexmedetomidine, but personally, our experience with the clonidine is much better. So dexmedetomidine is also very good in peripheral blocks. You can use it in the peripheral blocks. Like both are very good, like a clonidine and dexmed, quite good. I think, and currently we should stick to, important, message is stick to, less toxic drug and weight-based drug dosages, so that you don't exceed the toxicity in small children. Always use a weight-based, per kg or something like that. The second is don't go into that severe depth, because when you are practicing occasionally, you can go various depth in small children, because you don't have that inclination that like in adult cases you are just poking in, but that you don't do in small children, because going in the deeper you can damage the structures. So each and every block that has got a like in epidural space, so even the spinal space. So while giving the spinal, you don't go too much of inside, injuring the cords and go in a sucker. So that's the depth of is very important in a small children. One more is when you are having a resistance in the injection, just stop it. Okay, that's a very important thing. And if you think that toxicity is, I think always your ear should be at the monitor when you are giving the pre-operative and post-operative, not post, but when you are giving the drug, the ear has to be at the monitor. Any changes in the ECG or any changes in the pulse rate or BP, immediately you should draw the attention. I think this topic is really endless. Samir is, I think, getting bored probably.
Yeah.
Looks.
I am here. I am very sorry. I joined late. I have finished my case just now.
Yes, this is the topic of we have just selected the few blocks, because advanced block we common practitioner they don't use, like a QR block and rectus sheath and all. We do give instead of a thoracic epidurals, we give erectrospiny or for this thoracotomies and all. A lot of things can be talked. Actually, it can be very simple or it can be very terrible, regional anesthesia. If you like it, you like it. If you don't like it, you just don't like it. That's the way.
Okay. Hello, Samir.
Pradnya, I have one question. This is okay what we are talking in thorough details for the institutional practitioners and all.
Correct.
But still some private practitioners are scared of, and they come across the occasional this pediatric patient, might be sometimes orthopedic surgery, sometimes maybe simple herniatomies or these things, and they can't refuse those cases. Even in that case, sometimes it is the general surgeon who is doing these cases, or the orthopedic surgeon per se, not the pediatric surgeons or the
Correct.
pediatric orthopedic surgeons.
Correct.
That time, my first question to you, you have done a tremendous work in regional, pediatric regional, and what you advise all such people? My advice is to attend the workshops and get trained themselves, stalwarts like you people, and they are doing it. What is your advice, and how many times they are scared of nerve injuries because sometimes when they are giving peripheral blocks in pediatric patients, that is the information from lot of peripheral people and then nursing home people they are still scared of. How to relieve that from
Fear.
their anxiety?
Yeah. Yeah. So actually, in this presentation, I told him to select a few blocks where the practitioner can practice. Okay. Like the most easiest block is the axillary block. So you need not have a PNS, you need not have an ultrasound also, a simple needle which will go inside the supra, axillary artery, and you can just deposit a, local anesthetic along with this solution. Okay. That's the easiest block. Even the femoral block is the easiest block. There you will not make, dreaded mistakes in that. Okay, these are the point. I'm not telling you to give an interscalene and supraclavicular block. These blocks we don't tell in common when we are talking about this thing. So here I give a message to those who are, don't worry about that. You can make a mistake, but you will not have a dreaded complication with these simple blocks. Like in a caudal, if you think that once you feel that caudal, it is like giving a spinal. Okay, once you have that feel, immediately caudal is the easiest one. You did not go for the lumbar one. You can put a caudal single shot, or if you don't wish to put a catheter, you can give at the end of the surgery. You can use additives. Okay. So private practitioners can use this. Simple hernia block is there. Penile block is there. Infraorbital blocks are there. For these all hydrocephalus and all surface, especially like a CTEVs and hydrocephalus surface blocks can be given. Simple blocks are definitely all that can be given. You don't have to give advanced blocks. And don't fear. Few things are there. Okay, first of all, I said, you select your drugs. Okay. If you want to select, you can use all drugs, provided you use the, limiting dose of per kg. You just calculate the dose so that you don't, exceed the dose. Second is the depth, which I have already talked, because the people can go, depth and cause an injury. That is a major fear. Okay. So don't go into too much of depth. Okay. You can use the PNS and see the response. You can see the UAG. Of course, this will take some time, to have a learn, because this is not a everyday people like us every day. So we are blindly also we start giving it. We know that is perfectly, it is there. So, but they can take some time and do it. That's not a problem. Third is, when you just be prepared, because most of the time these patients are under general anesthesia, or they must have given some ketamine or just ketamine and block. Okay, that is also okay. I'm not denying that, because some of the facilities may not be there at the remote place, like giving in a spinal anesthesia. I never say that the spinal should not be given, at all, because in the remote places, the epidural needles are not there. So you can definitely give a spinal. Okay, but that limit the dose, and when should be, how much should be given. You should not be given, so that too much of hypotension there. First, you learn to make the dosages per kg. Again and again, I am telling you, because that is very important thing. In a pediatric anesthesia, you give the doses, accurate doses. Don't give arbitrary, because as we have already been telling you, these are not a mini adults. You give a 1/4 dose or 1/5 dose. No, you calculate the dose and give. And what I should say again, if you are well versed with the USG, definitely you can use the USG. Once it will fail, second it will fail. If you are using the additives, it may give a very added advantage. Provided it's a persistently, you start giving persistently and you will recover perfect, basically. So Dr. Sale, आम्ही तर तुमच्या इथे वर्कशॉपच केला होता. So we would like to do a repeated workshop, definitely. it is in my mind, but I'll make it a point that, actually we have a, observer sheet. Many people can come, 1 or 2 days, and they will get to see the, many blocks in 1 or 2 days. That fear of, giving the block will go away. Once you see that, these can be done, so it was much easier. I think it is need to have a workshops and hands-on probably.
Okay.
Just by seeing it also, I think I one sentence I still remember in 2006, I had done this workshop and Avinash had come. So a lot of people from even the Samir had come. And after seeing those blocks, they have started giving it. This is, I'm talking about 2006. So even if you see somebody is giving how it is, or it is quite, can give a courage to give. Otherwise, just imagining, nothing can be happened. Workshop kara.
That was orthopedic reconstructive surgery camp by Rotary Madam.
Orthopedic?
Reconstructive surgery camp at Lilavati.
Correct. Yeah.
Right.
So once you do it, then you are very confident. Okay, this can be done. Okay.
Can I make one comment on this?
Oh yes.
Pediatric anesthesia and pediatric regional is very close to my heart. As you have mentioned rightly, ma'am, and Vineet, and also most of the private practitioner, which people like me who are working in nursing home setups and may not be working with pediatric surgeons all the time. As the I wonder, still there is a rampant practice while doing the circumcision in kids. People like to intubate. They are not ready to use simple penile and ring blocks for these circumcision cases. Forget about those caudals and this. But,
no, but
once the surgeons, once your anesthesiologists are pushing, we have to really push them, our techniques to convince them initial phases. And once they are satisfied with the results of this, forget about those deep blocks and auxiliaries, and that is far away. For most of the people who are working like me in the nursing home, you have to really convince the surgeons initial phase to start with the simple regional blocks. And once they see the results and the safety, they will start liking it, and you will be able to move further into more blocks. Spinals, I'm routinely using for hernias. I'm not very conversant with hernia block, but I'm very conversant with spinals, and it really works wonder with those. So no harm in, I don't think there is any harm in giving spinals for initial phases. Once you are getting conversant with these simple techniques, which spinals you are using in adults every day. So start using, as madam has correctly mentioned, in the correct doses according to the weight of the babies, and you get yourself confident in handling those cases. And the dictum of putting endotracheal tube in each and every patient for each and every surgery will slowly reduce. That is what I feel. Thank you.
No, I think that fear of, airway is also a problem. Fear of airway, losing the airway, that is also sometimes, but I think airway can be taken care of. I think most of the people usually give a ketamine, or say, usually we do under the mask, and nowadays LMA have come. So there is no need of, intubation as such for the circumcision. Okay. That can be done very comfortably, caudal block or penile block, or not penile, two types of penile blocks are. So while you have to get used to it, this technique. I think personally, I advise, not because it is a Vadia children. Whenever these blocks are performed in the children, people can go, and visit, 1 or 2 days. Maybe, I understand in a private practice is very difficult to go out, for some time, and get the hang of it. But definitely, you are most welcome to come to Vadia children's, and 1 or 2 days, definitely you can get to see more blocks, and you can get a confidence to do that. The way, because we have got a huge list, so our turnover is very fast. So you will also see how fast it can be given, without any much toxicity. And suppose even if it occurs, how to deal with it.
Yes,
that is
madam,
also
It will
Actually,
take
now
definite.
pediatric and regionals are, this is a part of modern pediatric anesthesia. You have
Yeah.
to know that. It is
Yes.
like that. So that old, gold standard has gone of, intubating each and every patient and doing, and because post-operative, the way of the comforts are there, then the surgeon also at midnight also they are after you, okay, please give block. Okay. Even if you are tired, they keep on telling you, please, because everybody wants a peace at night. Especially, patients who are howling, if the blocks are not there, their father, mother, especially the elite group of, people, like children who are spoiled brats, if they don't have a post-operative pain relief, they start giving you the pain, over the night. So it becomes a very difficult to deal with these children. Like supra-major surgeries are there, orthopedic surgery, those who are very painful. It is a wonder, absolutely. Once you know how to give it, it is really wonder. I think all of this is a time to learn now.
Yes, madam. It is almost, madam, 9:30. So we'll, I think, stop here. It is.
Yeah, see, all these topics are quite interesting. They can go on. I think we'll have another session. आम्ही पुन्हा येऊ.
पण तुम्ही यायला तयार नव्हता, मी पाठीमागे लागून यायला लावलं.
No, but I can do chairperson and speak also, no?
Yeah.
Avinash, just 2 minutes. There is one question for Rasmi.
Yes,
Rasmi, are you there?
Yes, sir. Yes, sir. I'm there.
There is one question from Rajurkar only, Bhav Rajurkar.
Yeah.
Rasmi, you are working with different bronchoscopes. You said, what is your experience with the optical bronchoscope? Which you will prefer, a tubular or optical?
Yeah, the optical, I have personally have no experience about that. Actually, when I said I'm working with different bronchoscopists, like the one they get is the rigid bronchoscope I was talking about, and I always make it sure to attach my breathing circuit to that scope to check it. The optical, I mean, I think they are mainly used for the diagnostic purposes, or most probably for the foreign bodies which are lodged in the proximal portion, and those who are taking a very little duration of intervention. I feel that.
Okay. I think most of the questions are also finished.
Yeah, I tried to answer the chat box questions also in between.
Avinash, you can conclude the session.
And one thing I just wanted to comment to Pradnya madam, that 2006 workshop, we were residents at that time at BJ Vadia, and we were in the OT working. So that was a wonderful experience.
प्रज्ञाने एवढे वर्कशॉप घेतलेले आहेत आणि प्रज्ञाचं हँडबुक इतकं फेमस आहे. People, they started keeping in their pocket that handbook.
Yeah, in the same year in 2006, madam, she started all the preparations for the formation of that Paediatric Society National, and we were all, residents working in the library for the same. And I was very fortunate to witness, that period of ma'am when she was so active, and still she's very active. But those were the initial days when she actually started doing it, and at BJ Vadia, the OT, and then the direct relay of the live blogs in the auditorium. It was awesome. It was awesome.
Okay, thanks a lot. I think some few questions are there. You can give your email, all three of you, and it can be answered probably. They can ask you on your WhatsApp or your email.
Yes.
You should display your email and our WhatsApp number so that those who want to ask you queries, they can be answered.
9:30 वाजून गेलेले आहेत, I think.
Yes. I think, thank you all of you. Thanks very much. It was very nice.
Wonderful discussion. Wonderful discussion. Balavaskar, wonderful.
Thank you, Rashmi madam, Shri Gopal sir, Vinit.
Thank you.
Vedekar.
Thank you so much. I'm so sorry for the interruptions caused in between.
No, it's okay.
Thank you.
All the way.
Thank you.
Special thanks to Balavaskar sir, having spent the evening with us. And प्रज्ञा आमचीच आहे, प्रज्ञाला वेळ द्यावाच लागतो.
हो sir, order.
With short notice, sir, join this session.
Yeah, I would personally like to thank the organizers, the office bearers of Maharashtra State Chapter ISA, and also the chairpersons, Bala Bhaskar sir and Pradnya madam, for their valuable and expert comments. Thank you so much.
Thank you very much.
Thank you.
Thank you.
Very much.
Thank you.
Thank you so much for the opportunity. I hope I
Thank
did
you.
justice.
Thank you, everyone.
Thank you,
Good night.
everyone.
Good night.
Good
Thank
night.
We'll
you.
meet
Thank you
Tuesday
very much,
next month.
doctors, for
Yeah.
sparing valuable time.
अरे आता बाद झाला.
Stop recording.
Yes.